doing studies to evaluate the effectiveness of various treatments to see is this treatment more effective than this existing treatment? Can we document through actual evidence that this works better than that? And if this works better, then we ought to get more physicians to use this better procedure, and we ought to reimburse for that procedure and not for the one that's less effective. So up and how the industry operates is more through experience. So you hear, and you've probably had your physicians say things like this to you. Well, I've had good experience with this drug, or I've had good results with this drug. And maybe he has had good results with that drug. But that experience that physician is relying on is sometimes not coming from scientific studies looking at that's controlling for all the possible factors that can confound a study. So if I give the two of you a pill and you both come back, well, I give the two of you a pill for the same condition. You come back and tell me, oh, this was a great pill. It was wonderful. I feel so much better now. You never come back and say anything to me at all. So my knowledge base now as the physician is this one patient that I gave the pill to has said, that was great. Right? I don't know the person I gave the pill to who didn't have a good outcome, who went to another doctor or who found some other solution to their problem. So unless you're doing a scientifically based study to look at the effect of one treatment versus another, you're not able to know if your experience is being biased by the fact that you have experiences that may be limited and not as fully representative of the total population. So what the Comparative Effectiveness Council is going to do is going to recommend procedures that should be evaluated and studies should be developed to compare different drugs, different devices, different techniques for dealing with different health problems to try to demonstrate is there an actual evidence base to prove that this really does work better than that. And I think that's clearly where we need to go. When you look at certain conditions, hypertension, for example, how many drugs there are for hypertension? Wow. So how do we know do we know if drug A is better than drug B? Well, for some people, drug A might be better. For other people, drug B might be better. Well, until we do the studies that demonstrate who is going to respond better to drug A versus drug B, and is drug C even better than both of them? Until we do those studies, we're not going to really know, and we're going to continue to operate on experience, and that also helps to drive up costs because there's an incentive to come up with new techniques, new drugs, new procedures, because you get paid for coming up with new drugs.
So is that the responsibility of the 15 panel? That's what you're saying? That's their responsibility?
To oversee the development of comparative effectiveness and its implementation into the healthcare system.
Okay. So what is your lateral question to that, Kenneth?
Well, my question is if they've moved to an area of research now, and most of the panel, although some of them were medical doctors, but if they're no longer practicing the medicine, how do they keep their hands, or not their hands, but how do they actually stay attuned to things that are on the cutting edge in medicine if they're not practicing, but they're out doing research? But then yet they have to come back and make various decisions about the medicine itself.
Well, I think they'd be doing both. I mean, you would have the panel, I would think, I mean, again, the details of who would be on the panel haven't been fleshed out, but I would suspect that the panel would have a combination of people that are pure researchers that do not see patients at all, because those are the people that are expert on how to design studies, and they can certainly speak to whether or not the study is properly designed. Then you're going to have physicians that are not researchers but are in practice entirely, and you'll have some that are both. I mean, there are lots of physicians, especially at medical schools and academic medicine, that see patients and conduct research, who can kind of talk from both perspectives of designing studies, making sure those studies are properly designed and controlled, and that you're getting valid results, but at the same time seeing patients and be able to understand, well, that may work in the laboratory, but that's not going to work in the treatment room, and here's why, and they have the ability to bring that perspective.
Wow.
I guess one of my concerns would be do we foresee a day coming where maybe my doctor and I are in the, examining room together, and he says, my gut is telling me one thing, but these are the regulations that are coming down from the team of 15, and they say we have to move in this direction. Whereas his gut is saying, but I believe something different. I mean, do you, how would you speak to that, or to, solve any fears that would be in that direction that maybe the average American would have?
Yeah.
Will this team override my doctor's gut feeling, who's known me for years or has watched my health for years and managed it?
I think that the role of the panel would be to set broad policy, not to deal with any individual patient or physician, but to set policy, to say that, for example, when should you start getting your prostate cancer checked? Is it 40 years old? Is it 35 years old? Is it 45 years old? I mean, okay. So we have panels that make those sorts of decisions. I've been on some of those panels where we kind of try to build a consensus about what's the best thing to do. And those panels are usually comprised of people like me that are researchers that don't see patients, but also physicians that don't do research and combine. And we try to look at the evidence, we look at the research, we look at experience, we talk it through, and then we try to come up with a consensus that says this is the best knowledge that we have, tells us that this is the best way to deal with this situation. So that panel would be setting broad policy. It wouldn't be telling your physician specifically, you can't give, Kenneth Jones that pill. But in a way, that happens. Mm-hmm. And let me tell you how that happens. So within a hospital, we have formularies. A formulary is the list of drugs that an insurance company will reimburse for. There are some drugs that they will not reimburse for because of many reasons. It could be, we're not going to reimburse for that drug because there's a generic version of that drug that's much cheaper, and we're not going to pay for the branded drug. Or they'll say the evidence that this drug is better than the existing drugs is not strong enough, so we're going to only reimburse if you use those drugs. And your physician is somewhat constrained in terms of, or has to figure out, how do I practice on this patient if this patient's insurance company doesn't have this drug on the formulary? I'm not, and he won't get, he'll have to pad a pocket for this drug. Yeah, you sort of have to figure that out. That happens currently. It may seem invisible to the patient because they're not realizing that the physician does have these constraints on them. Or certain hospitals have policies on certain procedures that they will or will not do that may not be evident to the patient. But that's policy that's decided, not necessarily the physician that's deciding. Mm-hmm. And currently, the physician is under. And I should be careful here and be clear that I'm stating now opinion, right? So I want to make sure that people, no one watching this construes this next statement as being fact, but it's opinion, but I think it's supportable opinion, that if you ask most physicians that accept both Medicare and private insurance, which has been more intrusive on their care, the private insurance company or Medicare, I'll bet you most of them would say the private insurance company has been more commonly said, I can't do this or I can't do that, than Medicare.
On that note, wow. We're going to have to end because we're out of time. Yeah. I'm sorry. I would like to hear the answer to that question. I'm sure you guys have.
Well, ask your doctor. Well, ask your doctor. I would love to know what your doctor says.
I would like to hear more about the answer to that particular point you were making.
We
there.
didn't talk about death panels.
Yeah, I know. That's one of the things I was looking forward to, the death panel. But we're out of time. Listen, we're going to come back and discuss more of these topics. We're going to have you back, Dr. Thomas Levis. Thank you for coming. Kenneth, thank you for coming and also representing the people and posing the questions you've posed. I'm Dana Thompson. Thank you for watching the Apostolic Forum. Let me just tell you this. There's times where you may not have Blue Cross Blue Shield, but you have to rely on that old rugged cross. But he'll come through no matter what. I hope you take this information, apply it where it can change your life, and also thank God for your health every day. Goodbye.